Really just an opportunity to talk a little bit about serious illness in the pediatric population in the state and the various people who kind of are working on that and what that looks like with complex illness in a pediatric patient, as well as we have, yes, Parvati here to talk a little bit about the patient experience as well. So unfortunately, one of our presenters had an emergency, was unable to come. She was the one who is the co-chair of the National Pediatric Advisory Council, and I'm on that council with her, so I'll step in, answer questions there. But we're going to start with Parvati, who's a parent and who also is an active member of this coalition. And then we're going to speak with our physicians, Dr. Ming, Dr. DeJong, who work with complex care and work with kids in this population, and tell us a little bit more about that. So I'll make sure people can share screens. And Parvati, if you want to jump in, that's great.
Thank you so much, Lily. Hello to everyone. Thank you for the opportunity to share our story. My exhibit A, B, C is my family. There's not a lot that I can talk about without actually everything that I do is on their behalf. And so that's my husband and then our two kiddos. And most of what I'm going to be talking about today has to do with the four of us and our experience in this unique, very different journey with serious illness in pediatrics. So much like I think most of the world, you know, when we became parents, we just visualized our life to be this beautiful road. Everything's going to go just as planned. And, you know, we got this. We read all the self-help books and we were like, you know, we've planned our entire life and our children's life together. Except it just wasn't like that at all. It felt more like this. And what was worse was that with each diagnosis or each turn or each hospital admission, it felt like we were having the same car crash over and over again. And while this may seem very dramatic, it really is not as dramatic at all. It's the reality, not just of my family's life, but pretty much most families that have a child with a serious illness. I don't know if there's a definition for it, but to me, any child with a rare disease or any child with a life-limiting disease or a chronically ill child where it's not just the flu or it's not just a ear infection feels like a serious illness where there is no break, there is no rescue, there is no end in sight. I feel like as a family that's dealing with a child with a serious illness, but I'll let the experts weigh in on that. To me, our life has felt like a series of car crashes that has never ended. So here's a little sneak peek into what that has looked like for us. So this is my son. He was born in 2008. So this is just a few of the highlights of pictures. I always feel like pictures do more justice than me just talking by myself. But as you can see, that very middle picture is him so cheerful and happy that he's missing his preschool, taking an x-ray because, you know, that was like the biggest thing we had to do at that point in our life was like take him for an x-ray, and he's so thrilled because they're giving him all the goodies. Well, clearly life in the past 13 years has not looked like that, as you can see from the other pictures, but truly speaking, this is how our life has been with him, having a condition that's terminal, but not immediate. He's not going to die anytime soon, but the reality is that he may. Because of a condition that he has. He has an ultra rare genetic disease. It manifests itself as cancers in different parts of his body. He is the only one known to us and known to the researchers in the world with his particular genetic mutation. So the billions of people around, since we are focused on North Carolina, here is one fact I would like to say: you do have one of a kind person, a child living in this state with this condition. So what does that feel like? Well, most of the time, thankfully, we have doctors who tell us we have no idea what this means, but we will do everything we can to help you along the way. Does this mean he's going to die? No, but is that a possibility? Again, yes. So, you know, him being him, the very bottom picture is him asking his surgical resident to show pictures of the colon when they took it out when he was 8 years old. Since then, he's had multiple surgeries. And like I said, each diagnosis, each surgery, each time we have a scan, it feels like another car crash because he's learning to walk again, and he's learning to eat again. He's learning to speak again. He's learning everything that as a 13-year-old he already knows. But everything goes back to square one when he has a procedure or he has a condition. So this is my easier child, my less medically complex child. So keeping that in mind, I introduce you to my daughter, Ira. Combined, both my kids have about 4 rare and ultra rare diseases. She's cute as a button. She was born with extra toes and fingers, and we were like, oh, that's really cute. We've never seen that before. Only to find out when she was 6 months old that she had a condition called Bardet-Biedl syndrome. Again, everything since then has been, oh, what does this mean? And then it was like, oh, a few more months, and now we think she has something else. And now we think she has something else. So in the 4 years that these pictures are taken, she ended up having 4 different diagnoses thrown at her. And most of her life has been spent in the hospital. She never made it to school. She never made it to preschool or daycare or anything remotely to that. So as you can see, doctors were her best friends, nurses, nurse practitioners, therapists. These people became our family. And what people mostly don't understand when we say our child is sick is that they're like, oh, so for how long? They don't understand when we say it's lifelong. They just give us a very clueless, like, what does that actually mean? That just means that we can basically never plan a single day. We never know if we'll show up for something, whether it's a school appointment or even a doctor's appointment, because we may be putting out that fire at home before we even make it there. That is truly living with a serious illness. She's had her ups, she's had her downs, and she's had everything in between. And we consider ourselves very fortunate that somewhere along the line, I think when she was about 1.5 to 2 years, her doctors were thoughtful enough to say, okay, there's a lot going on with this child, and this family needs something more than what just 4 different physicians can offer. And that was how we got connected to the complex care team and to the palliative care team. And I think one of the misnomers that we have since learned is that palliative care team is not end of life care. And I feel like that is something that I will keep advocating and creating education and awareness for the rest of my life. But it was very hard to be told, oh, we think you need to meet this team. And they immediately followed it up with, she's not going to die, but we still think you need to see this team. Fast forward to a few, so what does it look like? This is exactly what our life looks like. We've had 2 kids in the hospital, different hospitals, same hospital, different floors, same floors. One's been in surgery while the other needs an infusion. Just as our family of 4, my children's second home is UNC Children's, but we have also have 3rd and 4th homes. We go to Boston Children's, we go to Cincinnati Children's, we've gone to Levine Children's. I've driven my daughter to Levine Children's twice a week for her to get a very special plasmapheresis. This is very hard for most people to understand because they don't get why we have to do this. But the reality is we have to do what we have to do to keep our children alive. And that takes a lot more than just, 2 parents taking care of their child. Because while one child is sick, but he can bounce back a lot faster, he also had to deal with the fact that he wouldn't know if his mom and his sister would come back if they went for a procedure, because his sister would get really sick and stay back in the hospital. So these are the emotions, these are the issues we all face, not knowing when we leave our house if we will come back and what that looks like, and if we go into the hospital, how long we'll stay there, or what that is going to look like. So this is just a quick snapshot of our life through all these years. And I always add these because one thing that we did not know then, and we are thankful for, and why I advocate so much for palliative care and I advocate so much for complex care, is that now when we look at these pictures, we see the difference of what our child went through. But the experts saw it before we did. And the rightmost picture is of my daughter celebrating her 4th birthday. 2 weeks after her 4th birthday, she did pass away. But 6 months before that, the palliative care team did tell us that, we had a talk, we had a conversation. By then we knew them so well that when we had to sign that DNI form, or we had to sign the most form, we felt comfortable that that was the best decision our family wanted or needed. And, even though our daughter was completely nonverbal her entire life, we felt comfortable knowing we made the right decisions for her and on her behalf, because we had that extra team helping us navigate this really complex journey of understanding, even if she cannot talk, what do you think she would want? And that's not something I feel like most doctors understand unless they work in this space, or more healthcare teams understand. We had nurses leave us when they came to know that our daughter had a DNI form. They were not comfortable with it. They were not comfortable with palliative care. They were not comfortable with hospice, even though we had the hospice team help us train them. They felt they were so attached to our daughter that they did not feel like that was the right decisions or the care. And we had to let them go, because even though that meant we didn't have any respite or support, it was the right decision that we had to make. These are very complex issues that we ourselves needed help figuring out. And the only team that could help us was a combination of the complex care team and the palliative care team. So most of the times, this is how we are. This is reality. I don't look like this all the time. This is more an indication of how parents along the state usually feel like when you have a medically complex child. This is how we walk around. That road that I showed you is actually not even like that. It's like this. This is our reality. There is no one day that looks normal. There is no one journey that we can plan without deciding what the roads or bumps are going to be. How many hospitals are there in between our destination where we may have to take our child? Is there support? What are we going to do? What are all the things we have to pack in our car before we take our child, even for her medical appointment or his medical appointment? So if anything today, I hope that as you all go forth and continue to help us figure this out, that you remember that this is not an easy journey, but it's not a journey that we ever wanted to sign up for. And it's not life choices, it's not health choices, it's just either genetics that we didn't know we had bad genetics, or that it was something that just happened, but it exists. And I'm just one family. There are so many other families in our area that don't have that support. And then I hear stories of families losing their child and going away to rural areas within the state. They come to UNC and Duke because of course they're the best, and they want all the answers from them. Their child goes through all of this and they travel back and forth hours together. And then when they lose their child, there's absolutely no support for them after that. They feel isolated, they feel alone, but they also don't have palliative care. They don't have that team that comes home and trains nurses. They don't have that team that says, if you want to stay at home, we will do everything for you to stay at home. There was one time I was running a mini hospital at home. My son had an ostomy. He had a central line, which he was getting IV nutrition. Our daughter needed suctioning. She had oxygen. She had a G tube. This was our reality. This was our life. And thank God we have virtual health now. I wish we had it 4 years ago, because our life would have been so much simpler instead of navigating 2 medical bags, 2 wheelchairs, 2 everything to take both our kids. But we live and learn. And so now I'm advocating for virtual health appointments just as much. This is all the parenting books that are available in the world. If you ever want to parent a more neurotypical child, which, there is no one normal child, this is how it feels like living with a child with a pediatric serious illness. I couldn't find a picture where the child was buried under the ground, because that's how it really feels like. We have a long way to go before we get to liberation, but our children and our families are nowhere close to even equity. So as the coalition, as you go along representing what you do in a larger frame, whether in the hospital system or in any national boards, I hope all of you just remember that pediatric illness is not receiving as much attention, but our children matter just as much, our families matter just as much, and all our practitioners need help, either from the hospital system or otherwise. I feel like they don't get support, they don't get help, they don't get recognition that they need. So I really, really hope that you remember we have a long way to go, but we have to start somewhere. And so I'm really thankful for all of you for giving us this opportunity. And I leave you with this. This was taken even 3 years ago after our daughter died. she would have been in kindergarten. So I took her a replica of a doll that was made in her honor, along with her beads of courage. If you don't know what these are, I really, really hope you go learn more about it. But each of these beads signify a hospital visit, a poke, a therapist appointment, whether it's rehab or IV anesthesia or whatever it is our children get. This was 3 years ago. My son has 300 more beads added to his. I hope that this serves you as a reminder that we are much more than our diagnosis. We're much more than what we can put in paper and words. We're real people with real problems, and a very small sect that needs everyone's help to get attention, funding, support, and everything else in between. Back to you, Lily.
Thank you. Thanks, Parvati. I really appreciate that. That was a really good overview of what it's like, because I think that while it is unique for everybody, I think your story of the journey and all of the curves and all of that is so common for all of the families. So I'm going to turn it over now to Dr. Ming and Dr. DeJong to tell us a little bit more about the complex care teams and how they work with kids.
Thanks, everybody. Let me get my screens kind of situated here, and then if everyone can let me know if you see this okay. Are you seeing those? Some thumbs up there. Okay, great. Let me first introduce myself, and I'll let Neal introduce yourself, and then we can get started. My name is David Ming. I'm a med-peds trained hospitalist here at Duke. I've been here for a long time and had the privilege to work with many children with medical complexity and their families, and partner with Lily and her team at Transitions Kids for many years. I helped to develop and found our Children's Complex Care Service, which is an interdisciplinary complex care program housed here at Duke. And I have done a lot of research in this space, thinking about systems level interventions to help improve and mitigate some of the challenges that Parvati just so eloquently highlighted for the group. So let me pass over to Neal for a brief introduction as well.
Hey, everybody. Thanks for inviting us to join today. And Parvati, thanks again for sharing that. I think everything else that will follow is, just picking around the margins of the story you just shared, which we should probably all keep foremost in mind as we talk about, these sort of more professional and system issues that are all inadequate to the challenges that you described. But I am a general pediatrician at UNC. I direct our children's complex care team, and I'm fortunate to do health services research with David and others on the call. I've had a chance to work closely with Madeline Moriali, who has been a close partner of ours and is here on the call. And maybe, Madeline, we can give you a chance to introduce yourself as well to folks who may not know you. So thanks again for inviting us.
Good morning, and thank you, Neal and David, for inviting me to join this meeting with all of the rest of you. I'm a public health lawyer. I work with Legal Aid of North Carolina. We're a statewide nonprofit law firm that provides free legal services to low-income families and households. And I direct our statewide medical legal partnership program. So we've been working with Duke Peds since 2007, UNC Peds since 2010 or 11. And other health systems, large and small, across the state, to collaborate, to bring sort of our legal skill sets or legal remedies to the efforts that so many clinical practices are undertaking to address the social drivers of health, things like poverty, income insecurity, lack of health insurance, children needing help with SSI or IEPs, and sort of the full range of housing, food, all of the things that many families face, but are particularly prevalent among the families that are served by the complex care programs at UNC and Duke, and also elsewhere in the state. And we were also part of these convenings that you're going to hear more about. Thanks.
Great. So we really have three objectives here, but I also want to piggyback and really emphasize some key points that Parvati brought up in her presentation, which I hope come through as we talk about some of our work at the system level, trying to think about complex care more broadly across our state, how we went about conducting several virtual convenings to focus on systems of care improvements and think about the future, but really frame that when this powerful presentation that Parvati shared. Again, I would really emphasize that although I think Neal and Madeline and myself are being presented as experts, we are not the experts. I think parents like Parvati are the experts. And so I think it's really important to keep that in mind. And I think this notion of not just living or surviving with serious illness, but what might it take to thrive, and for the children and their families, and what might it take to get to that image that was shared at the end, so that the broad range and spectrum of children with complex needs, kind of across conditions, really think about the consequences that are faced that can be heterogeneous and intersect between their medical and social needs are addressed. Because I think there's a lot more that's in common between a child who has a 1 in 6 billion, literally, genetic defect and the consequence of that condition, as well as children who have more common complex chronic conditions and consequences of that. So I just want to kind of frame that up as some really guiding thoughts that really struck me as I was listening, reflecting on what we'll be talking about today. So we do have a couple of key questions that we would love for you to be pondering and thinking about as we go through this today. Thinking about what are the themes, challenges, or recommendations that are most critical areas that a coalition like ours should be addressing. And I would say generally coalitions as well, because I think that regardless of the name, we all want the same thing here, which is better systems of care for children with chronic needs. What are the next step initiatives that we are discussing today and maybe best positioned for success? And how can we best align? Emphasis on align, because I don't think that it does anyone any good for us to be siloed and segmented in our approaches to advocacy and trying to improve systems of care. So talk briefly a little about the formation of what we've done here. And I don't think that this schematic is really going to do any justice, because I think what Parvati described just hits it so powerful in the nail on the head. But in a much more dumbed down visual here, this is what a typical year may look like for any family of a child with complex health needs. There can be a lot of clinic visits, some primary care, some specialty, maybe planned or unplanned visits to the emergency room. There may be surgical episodes or events. And what the challenge, at least from a health system perspective, is we're often quite reactive to those major events. So imagine leaving the hospital after a prolonged stay. There's all this effort into trying to get ready, make appointments, transition, handover. But those efforts are often, separated from everything else. These question marks are all those days between visits. And even in our experience, many children, even who have serious illness, high service needs, high medical needs that are very intense, on a typical year, a lot of days are spent at home, not in Duke Children's Hospital or UNC Hospital or Levine. So the question is, who's responsible for that interstitial space we call between those visits? And the truth is, the system is not set up to give you help, it's parents. And so that creates the sense that a lot of the care is actually fragmented, not integrated. There's a lot of silos, and the person who's trying to glue this all together are families. Now, the issue of defining complexity is one that bedevils me, and I won't propose as if I have a succinct, clear definition. I know that was one of the questions that Lily asked us, but it's kind of like trying to throw, darts at a dartboard, or the background here is one of these old magic eye things. For those who may remember those things, you stare at it long enough and you see something. So sometimes I may see one child in front of me as complex. Neal may see a different child as complex. We are both right. And this is why at the clinical point of care, reconciling that with system level data is why this quote from this paper is, I think, spot on. Identifying children with complex needs is not straightforward at the population level. Thinking in general, we know that the vast majority of children are healthy. And so the medical neighborhood in this schematic is pretty straightforward: a medical home, a dentist, and correspondingly from a systems level, accrue relatively low health related costs. About 1 in 4 to 1 in 5 children are categorized as children and youth with special healthcare needs, which has been a term used for decades now to identify children who have or are at risk for chronic conditions and may need more services in general than children without a special healthcare need. And you can see here in the schematic, the neighborhood gets a little bit more complicated, perhaps actually specialists or other services. And correspondingly, because of those needs, these children will have higher costs than children without special needs. An important subsegment of children within the CYSHCN bucket are these children that we use the term children with medical complexity, or CMC. And the neighborhood gets complicated in a hurry. This is multi-specialty, services in and outside of the hospital, medical and non-medical services. And not surprisingly, despite being a very small proportion of all children, it's a disproportionate amount of costs. So these are some rough ways that we've thought about in the literature and our work to how we try to categorize complexity. Again, recognizing that even these descriptions, in my opinion, are still relatively blunt. In general, one of the things that really resonates me with the framework that underpins the definition of CMC is that instead of this focus solely on listing conditions and listing or delineating high patterns of resource utilization, we also think intentionally in this framework about what are the downstream consequences, because there are needs not only for that child, but also for their family in terms of family stress, work level, and family identified needs for various services, as well as functional limitations. So in this picture here from an old journal article, you can see for this child all the various technologies that are needed for daily living and the impacts that has and the limits that that child has because of their underlying conditions. So this is just a helpful framework that I've always kept in mind when I think about, well, who exactly are clinically CMC as a population. Now we contrast that with a very simple diagram that includes also adults. We recognize that most children, and frankly, the majority of even adults numerically, do not have chronic conditions. About 40% of all adults have multiple chronic conditions. I think of that as an adult analog to children with youth with special healthcare needs, even though the proportions are slightly off. But within that bucket are some of the children and adults we are talking about with serious illness, CMC, those who are seriously ill and have multiple chronic conditions, 5+ chronic conditions in the adult space. And obviously, you get further up here, the medical complexity level, the consequences, the needs, limitations rise. But important to recognize that those needs and the impacts are quite heterogeneous, just as the conditions are. And so, really thinking at a system level, we're thinking about what are the needs that are common, what are the approaches that are common despite this heterogeneity. One of the ideas and concepts that really led our work within this coalition that we've developed has been thinking about complexity, not just from a medical health doctor, health system sort of lens, but recognizing that complexity really sits at this intersection between medical and social needs. So in our schematic framework here, we think about this blue circle as the big 1 in 4, 1 in 5 kids who are children and youth with special healthcare needs. The small green circle is those who have medical complexity. But we know that many CMC, many CYSHCN have intersecting social needs, high social needs, for example, exposure to social drivers of health, adverse childhood experiences. And when those intersect with high medical needs, that only further amplifies the complexity of their overall health needs. We also recognize that just because you are a child with special healthcare needs or medical complexity doesn't mean that you have these intersecting social needs. There's also many children who have complex social needs who do not have medical needs. So our term of CCHN, complex health needs, really sits at this intersection, this striped area where there's overlap between medical and social complexity. And this really acknowledges that for these patients, the ecosystem is so much more than where are Neal and me in here? I don't even know. We're somewhere right here, right? There's so much more. And the data has been clear that the population level, medical care delivery is responsible for about 20% of health outcomes. Social and economic factors are responsible for about 40%, and that's just reality. So I think it's important for us from a health system level to recognize that we are just one player in this ecosystem, and that families rely on this huge system of care, which is an array of those supports and services in the ecosystem. We know that there's some national standards that have been developed for CYSHCN that can help think about how we can approach system level interventions and improvements. And there are state level mechanisms like Medicaid and Title V that can help us to be able to do that. But it's important also that as we embark on any sort of system level work, that any efforts to intervene, improve the system, have to be seen through the lens of, is this helping the people, the children and the families, as well as their frontline service providers who actually are taking care of them? Because if our intervention efforts are not helping those people who are the ultimate users of the system, then we're missing the mark. So when we set out to form this coalition, this was a partnership with the National Center for Complex Health and Social Needs, which has a clinical arm called the Camden Coalition. And they have been funding for several years now regional convenings focus on complex care, bringing together organizations typically in the community to try to think about how can we solve some of these big, hairy problems of system levels care for children or patients with complex needs. Ours was the first ever child-specific complex care convening funded by the National Center. And we really were excited to have this partnership with many of the entities listed here. And as we have framed up our work, we've really come to realize that the coalition we're describing today is interdisciplinary across sectors, but we all have a shared goal of improving systems of care for children with complex health needs, or CCHN. And we really envisioned a system of care ultimately that enables all children with complex health needs to thrive, emphasis on thrive. And our mission is really to promote the development, implementation, and dissemination of programs that forge a better path to health for children with special needs that begins and ends at home, in acknowledgement of recognizing that people have homes. Their home is not Duke Children's Hospital, it's not UNC Hospital. So I'm going to turn over the slides here to Neal, who's going to walk us through our work with the convenings.
Thanks, David. I'll just take a brief step back again and acknowledge that I think one of the really significant challenges inherent to trying to make policy about or improve systems for children with serious illness is that they are so different from the population of adults with serious illness. There are many, many more adults in terms of numbers who have serious, often terminal illnesses, but they represent a relatively small number of very well-known, often overlapping medical conditions for which we have very large systems of care and one uniform national standard in terms of Medicare that sets the standard with how we approach those systems of care. It doesn't mean it's a perfect one or even a very good one at sometimes, but the sort of endless replicability of childhood serious illness is captured, I think, by the vast heterogeneity of diseases that represent children with serious illness, and then the almost endless number of policies and programs through state Medicaid agencies, right? So 50 state Medicaid programs, more if you add Puerto Rico and others. And then within those, the endless number of endlessly varying home and community-based services waivers. We have CAP-C and Innovations. Other states have their own home and community-based services waivers that are endlessly changing and proliferating based on what states are seeking through the federal Medicaid legislation. So it's this issue of sort of vast heterogeneity with an overall smaller population that I think really captures the difficulty of making policy about and improving systems for kids. So in that context, what we sought to do was to form a coalition of advocates, interested advocates, including importantly and highlighting people with lived experience in the system of care. So David, you can go ahead and click the next one. I think it's going to make some boxes when you click the next one. So our first step was to form a 16-member advisory panel to help guide us through thinking about priorities in the system of care in North Carolina. We used that advisory committee to invite sort of like, snowball, inviting friends, right? We used that 16-member advisory committee to invite each of them 5 to 6 additional participants from around the state to complete an open-ended survey in which we asked people about what are some problems that you're facing in trying to get care and services for your kid or for your patients? What are some strengths that we should build on? And what are some things that we should do immediately right now? And we took all of those survey responses here in the third box and reduced them down into 59 general improvement topics. And then we had our advisory committee rate those based on importance and urgency. And we sort of defined importance and urgency operationally to try to get an initial set of priorities for our coalition to work on. Go ahead, David, next slide. So then what we did with those, what ended up being 21 most important and most urgent issues in the system of care, was we broke those out into a series of 3 virtual meetings. And these were the convenings that David referenced, for which we had a lot of planning and operational support, not only from our advisory committee, but from the National Center for Complex Health and Social Needs. And in the small dark blue boxes, you see we called those catchy little themes: health at home, health at the intersection of home and health systems, and at the intersection of home and communities. And actually, many of you here on the call participated in those and contributed to the recommendations that came out of those convenings. In the darker, the black boxes here, this is sort of our present work. So I'll skip over that for right now. David, you can go ahead to the next slide. This is just a quick acknowledgement by name of all the people who participated on our 16-member advisory committee. 4 of these people are parents of children with complex needs. Some of them had multiple roles, and then you can see there the parent representatives. and parents remained key to our work throughout the convenings themselves. I'll call out where that happened. Next slide. Go ahead, David. It's okay if you advance. This one I'm going to go over quickly. I mentioned in that flow chart before how it was that we arrived at a set of issues to prioritize. And it was through this kind of three-step process. So the world of potential improvements is endless. And so what we were trying to do is sort of crowdsource priority ideas from the world of people with lived experience in the state of North Carolina. And the way we went about doing that systematically was to first conduct these open-ended surveys, second, to kind of code that information to come up with a series of topics, and third, to have our advisory committee go through a systematic process of rating those things. Go ahead, David, you can go to the next slide. Just to give you a sense of who participated in that survey, we had 47 respondents who represented 31 counties in North Carolina. 2/3 of them were parents or family members of children with complex needs. About a quarter were clinical practitioners, physicians, nurses, social workers. 10% or 11% represented community agencies, and 13% had multiple roles or other roles. You can see there the demographic breakdown of our participants, and we did make that available in both English and Spanish. So we specifically solicited Spanish language feedback from families who preferred to respond that way. And as I mentioned before, on the right-hand side, we ended up with 59 potential improvement topics. Go ahead, David. This list I'm not going to read to you. This is the list of 21 topics. That among the 59, these were the ones that came out as representing the most important and most urgent topics in the system of care. These are written out in more legible font in a white paper that we produced about the convenings. We'll be happy to share that with you if you're interested in reading these. But we don't need to spend time reading these on this slide. Just to echo some of what Parvati said, palliative care and hospice for children, especially in more rural areas of the state, continually came up as very high priority and high urgency issues in the state, even though they affect a relatively small percentage of the pediatric population, as did things like behavioral health care services, social support. So in terms of broad strokes, those were some of the issues that came out. Go ahead, next slide, David. What you'll see on this slide is just a series of visual representations of what we actually did in the convenings themselves. So convening was and still is sort of a strange term to me, even though it is, I think, an accurate one for what we did, the sort of getting together to think about things. So these images represent what we actually did when we got together to think about those things. So in the yellow there were our kind of 4 team leaders for the coalition. In that lighter blue kind of aqua circle are our 16 members of the advisory committee. And then we limited invitations because we had to manage this whole kind of virtual group in small groups. So we limited invitations to a goal of about 70 to 80 participants for the convenings. And I think over the 3 sessions there in the dark blue, we had between 60 and 90 for each of the sessions, which we felt was feasible. Go ahead, David. These you already saw, the convenings we thought of as representing a series of concentric circles expanding outward in terms of beginning with the home and thinking outward in terms of the health system and the community. Each of the convenings, we had keynote speakers and then a bite-sized presentation that we really tried to gear towards specific needs and interests of families. So in the first session, it was from the Exceptional Children's Assistance Center, one of our state Family Voices partners who focuses on special education needs. In the second one, Madeline, that was from the ombudsperson from Medicaid to talk about Medicaid enrollment during Medicaid transformation and concerns about that. And in the third, we had a speaker representing Medicaid home and community-based services waivers to talk about those. At the top there in the small figure, so what we did is we broke up all of our 80 to 90 participants into small groups, intentionally allocated by their role in the system of care. So each group involved parents, professionals, community agency representatives. And then each group was facilitated by a trained member of our advisory committee who led them through a facilitated discussion of the topics assigned for that convening. And the goal was really to sort of elicit best practices and suggestions for improvements to the system of care based on people's lived experience. So this represents what we called a gallery walk. So people walked their way through different topics and had a facilitated discussion of that topic with one of our trained advisory committee members. Go ahead, David, next slide. So the next couple slides will give you an overview of the findings from the convenings. Again, as I mentioned before, these are better and more in a larger font represented in the white paper, which we'll share with you. Here, I just want to highlight what's in the red bordered boxes. So based on the discussions from the convenings, which we audio recorded each of the discussion rooms and had note takers assigned to each room to take detailed notes, reviewed all of the audio recordings and the notes from each of the sessions, and then used those to come up with a series of themes based on the suggestions and recommendations that participants had. So starting up at the top there at 12 o'clock on the clock face, funding and reimbursement was a major theme that came out in multiple domains. Training and education, mostly for the workforce or the lack of workforce, as we'll talk about more in a minute. Stigma, family support and empowerment, care coordination, cross-sector collaboration, and access to some key services. What branches from those are specific challenges that align with each theme and recommendations that came from the convenings themselves. Those are a little bit better spelled out in the tables on these next 2 pages. So each of the 7 themes was then aligned with specific challenges and specific recommendations that came from those convening sessions. What we've been doing in the meantime, since those wrapped up, and these were held in January, February, and March of this year, so beginning of 2021, is working with our smaller group now of kind of ongoing sustained coalition partners to, I always use the word operationalize, to operationalize these recommendations into specific actions that we can take together. So I'll give an example of those on some of the next slides. So here's just some, for the 2 on this slide and 2 on the next slide, some examples of next step initiatives that our coalition is taking. And some of these will take the form of advocacy efforts, some may be policy making, others will be more typical quality improvement or research projects. The first initiative that we've decided to focus on is what we call professionalizing the complex care workforce. And this doesn't mean that we think the workforce is unprofessional. But I think maybe go to the right-hand side there where we have participant quotes. We can't expect people to do this kind of really difficult work without having some degree of a career track and potential to earn a good living. So the people who do this work, the in-home nurses, the CNAs, the parents who are not compensated for providing hospital-level care at home, are not paid well for the work that they do and are not connected to systems of peer support and professional development in the way their colleagues are who work at large healthcare institutions. So training and support for care providers, incentivizing careers in the care of children with complex needs, and developing and testing new roles are some of the things that we will focus our efforts on. And we're always paying attention to the larger policy environment. We are very hopeful that at the federal level, this large legislation that continues to be argued about endlessly can be passed in some form, and that the portions of that would sustain additional money for the home and community-based services workforce would stay in the bill. I know we're sort of all paying attention to that. Number 2 here is to create shared purpose to improve the availability, quality, and outcomes of complex care. And again, focusing on the quote, there's a lot of great programs out, but you don't know they exist and you don't know to go looking for them. I think Parvati talked a lot about earlier how meaningful it was for her to get connected to a palliative care team that really knows its work well. I think we do have some resources and some programs available in this state, and families are often surprised to learn about those many years after they would have been useful. This happens endlessly for me with our innovations waiver, which has a ridiculous wait list that is imposed by our, I'm not going to comment here about those things, but I'll leave it that the wait list is an unpopular thing. But nonetheless, families often find out about the innovations waiver and don't get on the wait list until their kid is 15 or 16 years old. And it then is almost meaningless for them because their kid's going to age out of eligibility before they're even eligible for the program. And the same happens with CAPC, that families don't find out about it until years down the road. The next is incentivizing and optimizing our investments in information technology. The quote here, I think families are never the barrier to sharing information. It's us in our different sectors trying to get around the antiquated ways we have of sharing information with each other. And I'm sure Parvati and every parent of a child with complex needs could tell us stories about, you know, the hurdles that they have had to cross to retell their story a bajillion times. Not that they don't appreciate retelling their story, but to sort of endlessly cover the same information because they're having to reinvent the wheel every time they meet someone, even though in theory we have vast repositories of information that don't necessarily serve their purpose. And God forbid you try to share information across different types of systems, say from a school system to a healthcare agency, or from a healthcare agency in one place to a healthcare agency in another place. You know, we are still faxing each other reams of information and waiting to see that the fax goes through. So I think this one is almost self-evident. We do mention here the power potentially of telehealth to link different nodes of care in real time. I think that's something that we still need to invest more energy and effort in. And finally, and we should really start with this one, this should not be fourth, this should be first, is making families partners rather than clients in the system of care. And the quote here, I think, is a really powerful one: to pay parents and families to be part of the system. If we're asking them to be involved, their time should be valued and they should be having roles that are paid. I might even go more strongly and say, we implicitly expect families to provide this care. You know, families are providing hospital level care 365 days per year at home, and we do very, very little to support them as a society. And this is not just, I mean, this is not just the responsibility of Medicaid. I think there's much larger levels of responsibility here for us as a state, as a society, as a system of care, to acknowledge the unpaid, unrecognized work that many families are doing and to find ways of supporting that. All right, so this is just a little infographic that David made that I really like. David's good at making these things that sort of captures what we envision our vision, mission, and work as a coalition to be over the coming years. So we are using these convenings as a springboard, as the start of a conversation for which we hope to continue convening people. So I'll steal that kind of buzzy word, convening, to organize and to advocate and to make policy and to, you know, implement quality improvement efforts around all of these issues. So at the top, as David mentioned, we envision a family-centered integrated system of care that enables children and families with complex health needs to thrive. We say our mission is to promote development, implementation, and dissemination of programs that forge this better path that focuses on the home. And we will do that by working to empower families to dismantle health disparities, promote integration across sectors, to advance the science of complex care where that's needed. And certainly, I think as this group is most interested in, to advocate, I'll add a V in there, to advocate for policies and programs that support families who do this work all the time. So I think that's the end. David had mentioned some key questions at the beginning that we'll reframe here. And David, if you could click to the next slide as well, we can jump back and forth between these. I know these were some of the questions, Lily, that you had shared with us from the larger group. So, you know, I think over the last 20 or so minutes, we've given a background of the work that we're doing, but we're happy to talk about any of these things that the group may have questions about. Thanks again.
Thank you, guys. This is awesome. I really appreciate it. Yeah, I can jump in. I know there are probably some questions, so go ahead, Catherine. I see your hands raised if you want to start.
Well, hold on. Sorry, we're sitting here with dueling computers and we're both on first. I just want to say thank you. You gave ideas that I steal as a person who's worked mostly in the adult world. I love the term interstitial care for what we're talking about, because I think that is the messy part of what anyone with a serious illness, be they child or adult, it's the part we have resources for, or limited resources for them, and everybody find them for themselves. So I want to thank you for that term. Other thing that I think is really important about the way that you guys broke up your recommendations was the 3 groupings. And I think, again, something that I want to steal very overtly when you talk about health at home, health with home and health system, and then intersection of home and communities, because I think we get those confused sometimes, and they all 3 have different strategies, but then the strategies have to come together. So I just want to thank you for that, and ask you the question of how can a serious illness coalition that has 170 plus members and 85 organizations help support what you're doing, and make sure that we stay in sync with you guys, because a lot of this is need to be sharing with our lawmakers and our constituents, whether we're talking about adults or children, but we don't want to lose you in that, because that's what happens to pediatrics a lot.
I'll jump in with one thing. Thanks, Catherine. I really, really appreciate that. And also the notion that the Serious Illness Coalition at large is, interested in children with serious illness and their families, even though as a portion of the total spend, which is often the way we think about things, unfortunately, it's a small group compared to adults. My first thought is the importance of just acknowledgement. I think acknowledging that interstitial space is and requires healthcare among children with serious illness. I remain pretty cynical about the fact that, one of the reasons the interstitial space, home, doesn't get more attention than we give it in pediatrics as a society is that no one can really make money on that space. So it's easier if we don't think about all that stuff as healthcare, because then we don't have to have, a responsibility or any accountability for meeting families' needs in those spaces. And that's a space that people shy from and kind of push onto Medicaid because no one can make money on that. Mm-hmm. And you see the way that plays out in policymaking, right? Try getting a private insurer to cover in-home nursing care services for anyone, or try getting a private insurer to cover intensive in-home behavioral health services for a child who needs those. I have tried and failed multiple times. I'm not trying to implicate any individual here, but I think as a coalition, first of all, acknowledging those spaces and the needs that exist in those spaces as places where healthcare occurs and needs to be monitored and supported and compensated and have its quality measured. And I think that's an important first step. And there's probably lots of steps that need to be taken beyond that, but until we would officially acknowledge those as a place over which we need to have some responsibility and shared accountability, I think it's hard to get anywhere until we acknowledge that.
Thank you.
I just piggyback. I just want to piggyback real quick too, Catherine, that as someone who is medicine and pediatrics trained, and I still take care of adults and kids, I really buy into the notion that kids are not little adults and adults are not just big kids. But actually, I do believe paradoxically with some of these cross-cutting principles around the systems, around the challenges, that we have more in common than we have different. And strategically, to your point of how do we kind of stay engaged and involved, I think is to everyone's benefit to have visibility and sight lines. And that starts with meetings like this, to where we kind of can know what one another's doing, what others are happening, and to always kind of acknowledge that there are opportunities for us to find cross-cutting interventions, programs, policies, funding potential and that we can probably do more together than apart. So I just want to add that editorialization as well, and really appreciate your comment.
Thank you. Thank you.
Thanks.
I mean, there are probably endless examples, but there are like some specific policy examples that we could take from that. Like during the pandemic, there was some temporary flexibility allowed for family members to be paid as in-home direct care workers for children on the innovations waiver. That's been allowed for a long time for adults with disabilities. I've heard it's going to be going away for children. But there are, other states that have really successfully developed and implemented programs, even for their medical complexity waivers, where parents or other kind of in-home primary family members can be certified as CNAs and paid to provide the care that they're providing in the home. And there's lots of sort of ongoing quality and research evaluations of those programs in, I think, Colorado and Ohio. So, even just using parallel policies between our adult and pediatric populations may be a pretty low-hanging fruit place to start.
We probably have time for about one more question, as this does wrap up at 1. If anybody has anything pressing they'd like to ask right now, we are all very accessible. It's one of the things that I really enjoy about everybody who presented today is the fact that they are all very accessible and willing to answer questions at any time. But is there anyone, I see Tina, your hand is up. Did you want to go ahead and ask your question? Or maybe your hand wasn't up.
Charlotte Sweeney in the chat that is, do you envision ever doing the work, having the quality of health we need to support a healthy population in a democratic country, inclusive preventive health services, serious illness across the lifespan, including end-of-life care based solely on our capitalistic business model, in contrast to National Health Service offerings, for example? I want one of you guys to answer that one.
In 2 minutes.
Yes, 2
I don't
minutes.
think it matters what platform we have or where we are. The recognition is still so far away. Is it a yes or no question? I hope not, but I think we're very far away. It doesn't matter what kind of healthcare, because I have been working with advocates and patients around the world. And when I listen to some of what they don't have, I'm thankful that we live here, that we have so much more accessible to us. But I think it's just it does not matter what kind of health system it is. It just matters how much representation we have and how much work we do to show the need. And I think that's where we lack the most, is coming together as a group to show that there is a need, and this is why it's important. There have been studies now coming up more recently about like burden study of the cost of having a rare disease or the cost of having this. But I think we have to step back and say, there's so many families that don't even get recommended to these more complex care services. So it's like, how do we get those families? How do we tap into them and show the need for them to have these services, and then have like a systemized way to capture the cost that these clinics are incurring by taking care of these families, and then identifying that. I think it's all in the money in the end. Like, no matter what we say, we're all here for the right reasons, but in the end, when it comes to policy, when it comes to legislation, it has to be what is the cost that these families, that these patients have on the system, and how is that going to, there's no rehab services for children. So when my child had surgery and came out, I couldn't take him to a rehab hospital. It's there for adults. Our children need it just as much. So it's much beyond that. I'm really making it easy for the last 1 minute that we have, but I think everybody coming together and taking the heart away and putting it in perspective of money is where we're going to get the answers from the legislative perspective, but also the education that's needed to physicians that are not working in this space to recognize and accept that this is outside our specialty. We can do kidneys, we can do brain, we cannot do everything that the complex care or palliative care doctor is doing, but training to recognize that it doesn't mean we're not good at what we do, we're just not good at what they do. And so we're gonna send our children to them. I think will be hugely implemental, just change in quality of life for the families and children. So more education and training, I think from that end also would be super helpful. Sorry,
Thank
that's not the
That was
question.
good. I was gonna say you tackled it. That was amazing.
Yeah, I would just say I'm cynical, but not that cynical. I mean, there's a ton of money in our healthcare system, and it moves around based on, you know, vocal coalitions of interest groups. And so far in the serious illness space, we have a bajillion different coalitions advocating for sort of different things. So I think one of the nice functions of groups like this, and, you know, coalitions like we're trying to build and align with others, is to unify and amplify the message that there are a few concrete things that we should move money towards, potentially away from other things.
Thank you. I appreciate everyone so much. It was really great to hear this from all of you. And again, please don't hesitate to reach out. And there's one more. Yeah, David, you put a good one in there. Read the chat notes before you hang up. It really
And
does.
feel free to email. Thanks,
Yes.
everybody.
Thanks, everyone. Bye.